And welcome everyone to the Women and Equality Select Committee on reproductive health conditions for girls and young women today. And if I could ask, first of all, Kim Leadbeater to start.
Lovely, thank you, Chair. Thank you for coming this afternoon, Minister. Lovely to see you and your colleagues. Straight in there regarding the Women's Health Strategy. When do you plan to publish a renewed Women's Health Strategy for England? And will it take account of the concerns that are raised by this inquiry? Because I think it's fair to say the 22 strategy was widely welcomed as a step forward, but there was some criticism that it lacked clear, actionable and measurable targets. So is this something you're going to address? So summary then, when's it going to come? What's going to be in it? And are you going to take account of what we talk about in this inquiry?
First of all, thank you very much for inviting us. We're all delighted to be here, and we certainly look forward to your report as well, because it will help us, not just for the Women's Health Strategy, as has been raised, but actually in the longer term. So I did want to put that on record, if I might.
Thank you.
When will we publish? We are planning to publish it in the spring, and you will have noticed we're heading that way by the weather. So that's sooner than often ministers say. That's the first general point I'll make. Secondly, what will be in it? I know that the committee will understand that I can't go into detail, but let me tell you how we've approached it. I was very keen on two things when I came into post. One was not to rip up the strategy just because it was a previous government, because basically it's sound. Basically we are making progress against it. However, there are gaps. It does need updating. It needs future-proofing. Things have moved on since 2022, and I'm kind of pleased we got that decision, really. What will be in it? I'm very keen, and we're doing this now, and have been for a while, looking at where, for example, there are systematic blocks, and there are a number, to progress on women's healthcare. The big issue for me that the committee will be very aware of: women's voices are not heard. I have been quite. Should I be shocked? I don't know. I've had the experience myself, I'm sure that many have, of finding it hard to find a voice, but also then being heard. And that, I think, has been our fundamental problem here in this country about women's healthcare. That, one, it's been neglected over many years, but secondly, women's voices are not heard. And you hear that a lot, and it's absolutely true. And every bit of engagement tells me that. So in the what, if in broad terms, we want to address both those points, that women's health is not neglected, that it is not a nice to, but it's core. I wrote down, and I didn't complete the third word. I've put when, what.
I think we were hoping to seek some reassurance that you would take into account the things that we do on the committee.
I'd be very keen to. I don't know when your report will be published. If for some reason it doesn't chime in, then certainly I don't regard renewing the Women's Health Strategy as that's it, because then we have to put it into practice. So yes, it will be taken into account. And the last thing I just want to say, of course, the other thing I'm doing here in my drive to renew the Women's Health Strategy is to tie it in with the 10-year plan. Absolutely critical. And that's another huge change since 2022. So,
can you tell us a bit more about that? How will the Women's Health Strategy align with the broader 10-year plan? Are there any examples of what that looks like?
Yes, actually. There's some very good examples. I think if we think about the three shifts in the 10-year plan, analogue to digital, to use one example, and I'm sure we'll come on to this, about how we get information to people, number one, and improving the NHS app. And also in terms of digital, again, I'm sure we'll talk about this more, but our introduction of the menopause check into the NHS health check, which I would love to talk about more here, and the impact that's had straight away, we still tend to think rather in an analogue way, don't we? We think about going to the doctors, seeing the nurse. But of course, so much can be done digitally. I use that as one example. So analogue to digital, that's one good example. The focus from hospital to community, you'll find, we'll talk about that quite a bit actually here. But I'm glad that in the 10-year health plan, I was keen to get this in there, the Tower Hamlets Women's Health Hub was in there as an example of good neighbourhood practice. I really wanted a women's health example of neighbourhood practice. And then sickness to prevention. Again, I'm sure we're going to talk about this more. Bless you.
Sorry about that.
Good health.
Thank you.
In terms of that area, sickness prevention, again, I hope we'll talk, for example, about the cervical cancer screening and the introduction of at-home testing. Again, new solutions, using technology, using progress to better serve women and to align perfectly with the 10-year plan. What I've tried to do, I would say to the committee, I've tried to mainstream women's health more, not to put it over there, because I think it's suffered for that. We are women, just over 50% of the population, so I really don't get the why I'm over there thing, and I'm sure the committee would share in that.
Yeah, no, that's really helpful, thank you. And I think the committee would probably agree wholeheartedly that it's very important that women's voices are at the heart of this work, and certainly we've tried to do that as a committee. But what about the lack of targets that was criticised in the 2022 strategy? Can you give any examples of how you're going to make things that are actually measurable and actionable, that people can actually see the results of?
We do want to make sure, when you see the Women's Health Strategy, we do want it to be something that people can look at and know what markers to put down. I'm going to turn to colleagues to see if they want to add anything here, but I would agree very much that is crucial. I mean, the sort of things we're already looking at, if you look at the waiting lists for gynaecology, and also extra appointments. But let me just stick on weights. Out of the total number on the waiting list, there are now, since a year and a half ago roughly, 19,000 fewer waits for gynaecology procedures. Again, that's a whole new area I'm sure the committee will talk to us about on waiting. So I will hold back, because we've got a lot to say on that.
Yeah, no, that's brilliant. Do
Yes.
either of your colleagues want to come in on anything I've covered so far?
Yes, go on.
Yes, so and obviously the waiting list data is going to be really, really important in terms of measuring impact. But I agree that, you know, the previous strategy was a bit less sort of clear on the kind of shaping of it. And this one will have more kind of direction in that way, and with some measures that will be associated. But I think more importantly than that, you know, we see the importance of measures in terms of how well are women now, how much of their health is their health improving, and we're going to be introducing measures at local levels so that systems can be looking at the progress when they implement the strategy and the changes. You know, are people getting better? Do they have better access to care? Do they take up more screening? So those kind of key things will be measured at regions, and regions will then report back. So I think you'll find that will be there.
Brilliant, lovely, thank you. Do you want to add anything, Tabitha?
I was just going to add that the Women's Health Strategy, we've done round tables with stakeholders in it, and I thought it might be helpful to just say what the themes of those were. As one of them was on women's health and targeted mental health support for women at all stages. One of them was about the menopause, education and raising awareness of menopause there. One of them was on preconception health and prevention of long-term conditions for women. There was one with DWP, chaired by Minister Smith and Minister Johnson, about women and work, which is a really interesting one. And there was one on women's experience, including pain. So, yeah,
That's really interesting, because I think, again, some of the witnesses that we've had here have expressed concerns that there's not enough new stuff in the strategy. So it sounds as though some of those ideas are quite new. And what can you say to convince, you know, the people that we've heard from, that women's health, including girls and younger women's menstrual health, which is the focus of today's session, is a long-term priority for the government?
Well, this is me asserting it, and I know you want more than that, of course, but it is a priority. I think when it comes to menstrual health, and I know you've heard from our Women's Health Ambassador, you absolutely will, I'm sure you've heard her say this. If you sort out, this is the thing that happens 12 times a year for X decades of your life, and yet it's not spoken of. And the big thing for me in the women's health strategy is, the big message I want us to give is women shouldn't pot up with things, which is what I think women do. We all do it. Then it's not just women, but women particularly do, because it's normal. It's normal to have painful periods. It's not. It's not normal to have heavy bleeding. It's that you should be seeking help. And I think we've moved so far from that it has to be key. I actually totally agree with Leslie about this is a really good anchor point. That's how I see it. And that's why I think I would say to you, you can be assured it will be in there, because it's such a core point of affecting all women. Similarly, we could talk about menopause, but earlier in life, and that's key, we've got an access point. I'm keen on access points like that. I'm also very keen on making every contact count. And again, I know Leslie speaks very powerfully about this, about just a simple question thrown in here and there can expose so much and pick up difficulties early. That's her key point. And as long as we don't normalise ill health, women will be more empowered, and young girls will be empowered to speak up. And if we move to, as we are already, you think about, we've just talked about community diagnostic centres. I think they're one of the most exciting things we're doing. Anyone who's experienced one will know how fabulous it is to see a quick service, personal service, all under one roof. That will make it easier. And neighbourhood health centres, women's health hubs, all of these are easier access points. In the same way we've moved, I'm slightly off, although women's mental health is important, but talking therapies is self-referral, because I'm, as you know, Minister for Mental Health as well as Women's Health. That to me is crucial, the easy access, self-referral, the information you can get online, and empowering women to say, I need help, and the help needs to be there. Now, that's quite a lot of ideals, but it's not a superficial ideal. This is the NHS we're building.
That's brilliant, thank you. And then final one from me, because I think colleagues are going to come in with more specific questions about menstrual and gynecological health. But what are your, as a health team and the Minister for Women's Health, what are your immediate priorities?
I think, do you mean like very specific things?
On women's health, yeah. What are the things that you're focusing on in the short term?
Well, what we've already done, I think I was very keen that we sort of put some markers down. I think it was a big moment. Not I think it was a big moment, but the reaction I got from the announcement to include menopause in the NHS health checks, I could not believe. And it was. I live in Lincoln, and I see a reflexologist who actually doesn't know what I do. And she said, have you heard what the government's announced? And I'm thinking, what on earth have we said? And she said that menopause will be in the NHS health check. She said, me and my friends are all talking about it because they felt recognised. That was the point. And we haven't even kicked that off, and women feel more likely to seek help. So my priority is to get women heard and seen and treated and diagnosed quicker. And so we've already made that one. The other thing was, I think it was October, was it? Emergency hormonal contraception available in pharmacies. Again, really good example of community healthcare. So tangible points like that, and reducing the waiting list for gynae, including getting women off those waiting lists who don't need to be on them because they can get their treatment somewhere else. So I'm looking for some immediate impacts as well as system change.
That's brilliant. That's lovely. Thank you. Yes, I got a few messages from some of my friends on that day that we announced the menopause announcements as well. Yes.
I mean, it was quite remarkable.
Yeah.
I couldn't have predicted it.
Yeah. Thank you, Chair.
Thank you. David.
Thank you, and great to see you here, Baroness Merron, and Dr. Mann as well, and Tabitha. Thank you. Yes, I think we're going to focus now on, I guess, the core of this session, which is about menstrual disorders and gynecological health. So, Baroness Merron, is there anything else that you've not mentioned so far? I know you've started to focus on some of the areas in relation to both those areas, but is there anything else that you want to see included in the health strategy that you haven't mentioned so far? And I guess we've talked a little bit about quantifying some of the things you want to achieve. So we talked about waiting lists, we talked about people getting better, and we talked about the take-up on screening. Are there any other areas that you intend to quantify progress through the new health strategy? And what are those measures?
I wonder if I can tie in, I'm in answer to the question, and thank you for that one. I'm thinking actually as we bring NHSE and DHSC together, I think it's a tremendous opportunity there. We already work closely together, but I always find it remarkable, I have to use those words. I do want to see them integrated. But I know, and Sue will have more to say on this, but for example, regions have already developed improvement plans in terms of women's health. They did deep dives into it over the summer, and they are they've developed their improvement plans. They very much focus on best practice, which I know will be of interest to the committee, and are following that up. But I know Sue can add more. So the reason I like that, if you like, is that is a system change which is embedded. And the other thing is, in the future there will be a national priority programme director, and that will include women's health and maternity. So again, bringing focus. I want to bring focus into our system. I know that the other thing, and again I'll turn to Sue for a bit more on this, the NHSE Women's Health Programme Board and Oversight Group, again, as bringing a rigour that I think has been lacking. So I know they're not sexy things that everyone can latch onto, but I think you as parliamentarians will understand if you don't, in fact your questions have already said this, if you don't nail it down, measure it, review it, ensure, it doesn't happen. It just does not happen. But could I ask Sue just to comment? Because the NHSE work's really interesting, I think.
That'll be perhaps, Sue, if you could focus a little bit more on what those measurable outcomes
what they
look
deliver.
like. Yeah,
Yes.
perfect.
So actually it sort of picks up on those improvement plans. So the improvement plans are sort of shaped through some really key aims, and the whole point of the aims are that they're what we call SMART aims, so they're very specific and measurable, and the kinds of things that they'll be looking at will be that secondary to primary shift, so trying to support women away from the waiting lists, looking at core high volume low complexity conditions. So what I mean by that is things like menstrual health, things like urogynecology, which is really one of the unsung kind of areas, which needs much more attention, menopause care, and LARC and long-acting methods of contraception as well. So, and then prevention, so looking at things like uptake of screening, looking at things like preconception care, bringing in contraception as a prevention rather than necessarily just a treatment, thinking about the whole system, looking at workforce, looking at patient experience or women's experiences, not just patient experience. So that will be sort of distilled into some key aims, and the data dashboard that I talked about will provide the measurables to look at delivery of those things across a whole population. So that's really, and trying to support regions and then ICBs and the local system to work all to the same goals. I think that's the way we'll start to shift things to better care, I hope.
Thank you. Thank you both. Baroness Merron, do you think menstrual disorders should have their own research categories separate from the current broader category of reproductive health and childbirth?
What would I say on that? I think I would say I'm sure the committee knows that, like, there isn't, you know, we don't bring NIHR, which is our, as the committee well knows, I'm sure, it's our research arm. It doesn't ring fence funding. I'm okay with that, because actually what matters is that, I was looking at this earlier, that, let's have a look, there is research currently into conditions like heavy bleeding, looking at and particularly looking at the diagnosis and care for teenagers, which is very much on point. And also the diagnosis and care for teenagers who have painful menstrual cramps, for example. I was looking at the figures, and last year there was 4.7 million directly spent on health of women and girls. I know, of course, we have to measure that up again, you know. One has to look at the comparators, but the NIHR welcomes applications, and whilst it doesn't ring fence, I think that the issue is getting quality applications in for research funding. That's where the emphasis should be, because if they don't come in, then but we're not. What's the word I'm looking for? What's the opposite? It's gone out of my head. But we are not just that's it, we're not just reactive, but proactively promoting the need for research and encouraging it. I think that's the key, and that's a whole another area that I think is useful in this regard. But I do think, for me, research is absolutely key. If we don't know the why, if we can't work out the response, and we can't be as efficient and effective as we would want to be. Any comments on, may I ask if my colleagues might add anything on research?
Absolutely, and if I can just add, I guess, you know, given some of the findings of this committee, and Dr. Mansell, you've been to some of our evidence sessions, and there's clearly challenges and gaps in provision for menstrual and gynecological health care for women that we all want to address. So I guess what we're asking should this be a thematic priority for the National Institute for Health and Care Research moving forward?
One of the things that, is absolutely key and important, one of the things that I know the NIHR is going to be doing is publishing a portfolio, which it's brought together to talk about the range of investments that are very particular to the health of women and girls. And I actually will look forward to seeing that portfolio published. I also think transparency is absolutely key, because it to the point I was making earlier, it will look at any gaps against specific topics, which is the point, David, that you are raising. but it will also signpost researchers to the areas of unmet need. In other words, where we're looking for that research. So I think women and girls' health is actually ripe for research, and we'd be very keen to see it. But that portfolio will really help us.
Do you want to?
Yes, and I was just going to build on that because I think that portfolio is really, really important, and I think keeping a focus on to just keep the profile on women's health research is really, really important. I just wanted to add that we have the Policy Research Unit for Reproductive Health, which is sits at UCL, which is really trying to look at what the emerging priorities are, and they have an ongoing portfolio of research which we work very, very closely with so that we can demand signal and then they can start designing these studies, and that's been such an important body to start sort of looking at what actually research is needed. Really, really keen to continue that and promote it.
Can I just quickly say on heavy menstrual bleeding, because I couldn't read my own writing, but I can now. So I apologise for holding this fact back. But the bit I wanted to tell the committee about was a comprehensive review, which was funded by the NIHR on the effectiveness of different treatments for women with heavy menstrual bleeding. Because why? Because we want that research to identify the best treatment options, which is exactly where we all want to go. I'm glad I could read it eventually.
Thank you. What's your assessment? So we've met Dame Leslie Regan as well a couple of times during our inquiries. So what's your assessment of the impact on girls and young women's menstrual and gynecological health care of having the Women's Health Ambassador? And do you intend to appoint a successor to Dame Leslie later this year?
I want to pay tribute to Dame Leslie. She doesn't just give a voice. She's just an enthusiastic, engaging, I don't like to say infectious in a health setting, but you know what I mean. Whatever the nicer word than infectious is, I'm sure Leslie will take it as a compliment. But that's what you need, and you need a strong voice, and you need someone who's not just a voice for others, but encourages others to use their voice. And that actually is what, and it's a pleasure to work with Leslie, because she does bring an energy, and you need that too. So I think it's been good. I also think it's very good to have a Women's Health Ambassador who challenges the government, when we meet privately, in the nicest possible way, who brings her own clinical expertise as well. And her own contacts. All that is very positive. My understanding is that Dame Leslie was appointed as the health strategy came into play. We are renewing it. I do think we've moved on. I can't give the committee an absolute answer, but as the committee is very aware, Dame Leslie's contract comes to an end in June, and we are already thinking about what is it we need, who do we need, what is the project now, because the project now is rather different to what it was when that Women's Health Ambassador post was set up. But we have other voices. Sue's a clear voice, as I found straight away. I don't just mean personally, but the role that Sue has is intended to bring that focus and voice as well. So I as I say, we are considering how we move forward.
So in light of what you've just said, do you think there's a case for a larger women's health leadership team? For example, a team of leaders on a regional basis or women's health specialties? And is that single women's health ambassador role really too big for one person?
Well, I think the job isn't just for one person. I think many of us have responsibility, and actually the people with most responsibility are people working in the field rather than the minister, to be honest. I think my reference to having a national priority programme director in the future is important. As I said, the regional development improvement plans, they all have to be monitored, they all have to report, etc., etc. So I actually have never thought it's a job for one person at all.
Could I just, on a couple of points, just ask for maybe a wee bit more detail? Are there any specific outcomes you're looking at from the UCL report? You said that you'd be, you were looking to what your priorities might be. So are there any specific outcomes you're looking for from the work of the UCL team?
The work of
the UCL team?
I think that might be, was that what I mentioned in terms of the policy
right.
research unit?
Sorry, yeah.
Thank you. So they have a very well-established programme of work, and they determine their priorities, and they have a series of outcomes and outputs which are then publishable. So, for example, at the moment they're working on something around looking at attitudes to contraception, so changing attitudes to hormone use and contraception, which is really pertinent because we know that there's a lot of shifts in the way that people feel about taking hormones for contraception, so that's really useful. They're looking at the commissioning structures across the system. Again, that's something that we know is a real issue for us, so working really closely with the sort of policy priorities and then developing the research studies that speak to that is how they've worked. And I think the way it's aligned is really, really helpful because it really feeds in directly to priorities, and they report very regularly on their outcomes. So, yes, clear outcomes.
And one other thing I wanted to ask was, Baroness Merron, the phrase you used was that you thought women's health was ripe for research. Would it be fair to say that that kind of implies that you feel that there hasn't been any research or there's been a shortage of research, and this is an area where there needs to be more work?
I think that's a very helpful observation. I don't think there's been an absence of research, but I feel we would benefit from more research. It also, the truth is, again, I'm sure this committee is aware of this, research gives a status to conditions, to practices, all the rest of it. If it's, and rightly so, actually, because if, as I mentioned earlier, if we don't know why, how do we answer it? So, yes, I feel there are a number of areas where research would be beneficial directly as well as indirectly by raising profile, yes. And also research will allow us to harness technology, I think, which is hugely exciting, including AI, which we are doing, for example, on breast cancer screening. These are things we couldn't have dreamt of.
Thank you. Kevin.
Thank you, Chair. And thank you for everything you've said so far. I'd like to look a little bit more particularly about the long-acting reversible contraception and gynecology in relation to waiting lists, changes to healthcare delivery, such as women's health hubs and so on. And actually, Tabitha, just quickly, I believe I worked with you sometime back when I was at NHS England, so I should flag that up first. You won't remember me. It was when I was at NHS England and was doing work with the Work and Health Unit. So yeah, so you wouldn't remember. But there we are. Just digging into these issues. Waiting lists in elective gynecology since 2022 have been really, really stubborn. They've just not been coming down as fast as I think anyone would like. Why do you think that is?
Perhaps if I start, we will all have views. My big thing on this one is waiting lists have been the only place that women could be placed. Whether they should be on a waiting list, the estimate, I'm advised, is that around 15% of women who are on gynae waiting lists need to be on gynae waiting lists. The rest could receive treatment in the community. So what worries me, and I'm sure will worry this committee, is that there are women who are waiting on waiting lists when, if they could be directed to services, particularly in the community, they could be helped more immediately, more efficiently, closer to home, cheaper for the NHS, but that woman would not have this waiting time for a procedure or an operation of some kind hanging over her because she doesn't actually need it. And again, I've heard Leslie Regan be very strong on this point. So I'm sure there are other reasons. However, would be mine. But I don't know if colleagues would like to add, because it's a very interesting area and it's the right question to ask, I think.
Yeah, and I think it's interesting because I think there's some, not positives, maybe that's the wrong word to say, but, there's been more of an awareness around women's health and people recognising that they don't want to put up with things anymore or shouldn't have to put up with things anymore, and go seeking help and care and go to their GPs. And the GPs only have had one recourse following, if they reach the ceiling of what they're able to give, then refer into secondary care. And so the waiting lists have grown and grown. And the system has, in a way, sort of outgrown that demand. And I think that the putting in place the sort of middle layer in neighbourhoods to say, actually, if you've got something that your GP can't manage, you don't necessarily need to be in secondary care, but you do need to have somewhere to go. So that's the whole basis of that sort of neighbourhood layer, to say GP is a really, really important part of a patchwork. And that patchwork is partly secondary care, but it's also a whole range of other professionals, and not just doctors, nurses, physios, more the multidisciplinary team. So that's really what we're trying to build. And I think it will take a bit of time. So because workforce shifts and things like that is going to not be straightforward. You've got waiting lists to deal with, and double counting at the same time to try and improve that community layer is tricky. So I think to see results immediately, I think we have to be patient, but I think it is the right way to go, and we're starting to make inroads in that.
And the Tower Hamlets the hub there brought out some of this particularly, I think, and you've probably talked to them already, but really demonstrating the reductions with only 25% of referrals needing hospital care, representing a 60% reduction, and things like that. So,
what do you think they got right in the Tower Hamlets hub model?
That they have been referred with, that they had the single point of access and triage to the right care. So yes,
I can build on the Tower Hamlets as well, because that's absolutely single point of access. I think is really, really key, so that referrals come to a central triage point. And what Tower Hamlets found is that if you review all the gynecology referrals, a third of them, GPs can work with advice and guidance and support and a sort of dialogue. And then a third of them can be managed somewhere in the community in this kind of interface layer, Women's Health Hub. And a third of them need to go to secondary care. So that frees up secondary care for the people that really need to be there. And their waiting lists have come down.
I don't know if you've seen some of their statistics. They're remarkable. Just to mention a couple of them. Building on what I said earlier, actually, a reduction in the number of gynae referrals that needed to be seen in secondary care in the first 12 months. Only 25% of referrals needed hospital care. I mean, that is transformative, isn't it? And then the other one, because it's interesting how many complaints, and as constituency members of Parliament, I know you'll know this, how many complaints there are about poor communication generally, men and women, in the NHS. Here, in Tower Hamlets, 95% of patients receive an initial response and they refer within 48 hours, 100% doing so within 5 days, as it should be.
I think it's interesting you mentioned Dame Leslie in this. I mean, she was characteristically forthright with us. I mean, she said she thinks that about 85% of referrals that are coming through to secondary care can go through a community or a primary health care model. It's a high statistic.
It is.
And she said that the current situation is ludicrous. So I suppose the real question is, given these really good examples and it can apparently be made to work on the ground, what's the government actually going to do about this and make this happen? And is this going to be reflected in any refreshed women's health strategy?
Yes, because it's so key. I think one of the other areas is our transformation on diagnostic services, which I've already talked only briefly about, but the community diagnostic centres, and we want to also increase capacity to include areas like tests to support diagnosis of gynae conditions. For example, to have MRIs quicker, more available, and the results quicker. Sooner you are diagnosed, of course, the sooner treatment becomes possible. But not just that on community diagnostic centres and opening more of them, but also expanding the hours they are working and the days that they work, because there is no point, as we have all learnt, having buildings, facilities, etc., that are not used. So investing in more resources, putting them in the community, but also having them open more. But honestly, just on if I had to focus on communication, that would be a full-time job, I think. I'm sure we've all seen examples of good communication and poor communication. This is where our emphasis on the NHS app is so important, because actually that is already changing people's awareness and of how to book an appointment, where to get information, and being able to access medical services through it. When I think about it, just a year ago, I'm doing things that I couldn't have done just a year ago, and it improves the situation.
And on doing things like learning from Tower Hamlets and making that more the case nationally, I mean, Sue might want to say more, because the kind of learning the lessons from women health hubs and making sure that that's fully incorporated into the neighbourhood health model, which is where lots more is happening this year, and where we're about to publish guidelines on that is a big thing. But I just also wanted to mention, in the context of waiting lines, the fact that NHS Online includes areas, these areas, diagnostics, menstrual health, as a priority, and that is really going to help to reduce patient waiting time, because it's delivering the equivalent of 8.5 million appointments and assessments in the first 3 years, which is 4 times more than an average trust. So that's quite a big dent. Yeah, thanks.
What with prioritising that in that system? What does that mean? How does prioritisation manifest in the system?
Well, they had to choose 9 areas to be there. They chose 9 areas, and this was one of them. So we sort of made it into that important list. Yeah. Main
work stream, and I think with all that, I mean, that's a lot of enabling things and actions to make things happen. I mean, where do you see the blockers? What are the blockers that have stopped this happening, and may still be things that we have to address?
Well, I think it needed capital investment. We've confirmed over £6 billion extra capital investment, so that we can expand capacity across diagnostics, electives, urgent care. I think, again, new ways of working. NHS Online, as Tabitha said, that is phenomenally exciting, about the shift that can make. I think that will make a really big change. And I should say, it wasn't an accident that women's health conditions became one of the 9, and very specifically it's for conditions like endometriosis and PCOS as well. Why? Because we chose some of the conditions with the longest waits and where online consultation works best. And it's the combination of that meant it wasn't an accident at all. And I know Tabitha wasn't suggesting, but an absolute deliberate choice. So again, back to blocks, I think we're not shy to take on the toughest. That's what I'm trying to say.
Absolutely, and I think also one of the blocks is, what we're trying to do is get the system to move, and it's a big beast, and in order to sort of help, and partly it's cultural, isn't it? It's, people working in different ways, people are very used to one thing, so trying to work with all the different types of professionals in that is hard. And we've got an organisation called Clear, who are amazing, who are doing some more detailed work with us on 2 particular women's health pathways. So one of them's heavy menstrual bleeding and one of them's urogynecology, and they're doing that fine detail of sort of what does this mean for workforce, what does this mean for shifts of funds, how do you make it work, and then using that to create a kind of workbook for the system so that then other areas can pick that up. So they're working with a couple of ICBs to kind of work out the fine detail, and then they'll be able to take that to other ICBs to go, okay, this is how you make that shift happen. This is where you invest in different ways. So I think that will be really, really helpful to the system to do that.
No, I was going to add, I'm sure the committee's aware, but I shouldn't overlook this. It's absolutely key. We're using capacity through private healthcare providers. We're providing NHS provision, but through capacity in the independent sector, which is right. Because why wait if the capacity's there? So we're harnessing that.
We've heard quite a lot about dysfunction in the commissioning system, particularly around LARC and so on. I mean, are there steps that you're going to take to really address that? Because these are really great ideas, but are you taking steps to really address the challenges around the commissioning of LARC? And also, I mean, how long is this going to take?
Yeah, no, it's been a real, every person in the system says this has been a struggle, especially, and contraception is a really good example of that, isn't it? That it's part commissioned by a local authority, delivered in NHS settings, and it's hard. And I think for people to find the bandwidth to take the time to find the solutions is difficult. I think that we know that the first step, and without over-egging the kind of the neighbourhood framework, we're going to be looking at how does that actually get implemented, and therefore what are the commissioning implications of that, and working more locally with people to try and sort of co-design and co-deliver commissioning solutions rather than saying do it this way, really trying to work out what are the barriers and constraints and how can we support the system to come together, because a lot of it is about communication, having the right governance structures in place and things like that. So that kind of more detailed work, and we're doing a regional roadshow to go round and work with the regions on that and really understand the barriers and think about the solutions and share.
I mean, I'm very interested in how, particularly as we're starting to move towards a neighbourhood health service, whatever that means, I think we're still, clearly that's being worked through. Where do women's health hubs sit in that? I mean, it's a slightly older conception. How are women's health hubs going to fit in with this neighbourhood health model?
Yes, we were talking about it before we came in, so I have to follow up. We were talking about it in some depth. Go on, Sue.
So I'm a big fan of women's health hubs, and they were a good proof of concept, and they were done very differently in different areas because of what was there before, and they evolved in different ways. And now we're taking that learning and we're saying it is absolutely important to have a hub or something that sits in the middle of primary care and secondary care. And it's really important to be able to deliver on those sort of core high-volume conditions that I talked about, but also take a bit of oversight for the population on things like prevention. So it's really sort of a central pivot for what happens in secondary care and what happens in primary care. So the hubs themselves, it depends if you're in a rural area, those hubs might be a more devolved, diffused picture. And if you're in a more urban environment, you might find, like Tower Hamlets, for example, have one women's health hub. That's fine because it's a relatively condensed population. So what they look like in practice is very different. My own hub where I work is a hub and spoke model, so we more sit out in the community a bit more, but it's sort of really population dependent. So I don't think we should be specifying exactly what that looks like, hence going towards this idea of the framework for delivery of that neighbourhood health centre provision is guided by these aims. And the proof is in the pudding, isn't it? You look at how well the population performs at the end of it in terms of their health. Performance is probably not the right word. How they feel. And then you'll know you're doing well. But that concept of intermediate care has to be there. People have to have somewhere to go. They can't have a coil fitted online. So there is something that needs to be there. It's just the configuration will vary according to local need.
I think perhaps if I could just very briefly say, I'm looking forward to, and it'll appear soon, the NHSE Good Practice Guide about for local commissioners about how to, and it's the point the committee's investigating in this discussion and a bit earlier about commissioning services efficiently, effectively to meet the needs of women, because every area has to, through its neighbourhood services, in my view and in our view, actually develop those neighbourhood health services to ensure that women's health needs are met. And for me, women's health hubs were the start of neighbourhood provision, and now we talk about neighbourhood health services. That's where the model's going, and we all embrace it. But actually, for me, it was women's health hubs who've done a lot of inspiration in that area. And as Sue says, they do take different forms, and I think that's fine as long as they meet the needs of the women in their area. And I've worked closely with NHSE, particularly on this, because of course they have been very clear at working with ICBs directly, and certain individual ones in particular, to ensure that the women's health provision is correct. And I've kept a close eye on that. Could we improve it? Yes, definitely. Have we got the right idea? Yeah, I think so.
I think I've lived in Tower Hamlets, and I now represent a rural community, and I think, definitely, I know quite a few members of the committee are particularly concerned about rural communities, coastal communities. Actually, if this is a model that's largely been developed in urban and metropolitan areas, how long it will take to develop these into a state that they really function in areas that, frankly, have been massively underserved by a whole load of health services. And what's the funding that goes with that? Is there transformational funding? Will funding for women's health hubs be ring-fenced as well, to ensure that we're actually not going to hit that consistent problem around medical misogyny and misogyny in the system, where women's services get overlooked because the funding isn't being properly allocated?
I very much appreciate the points you're making. Again, as parliamentarians, you'll be aware that our whole drive is to have local decision making to meet the needs of local areas for exactly the reasons that you say. If it's a top-down approach, that hasn't delivered as well as it should have done. I think we can see that for just evidenced in your comments. And so we're not prone to ring fencing, because areas vary. Unless it's for something very specific for a reason. But we don't generally do that. And we also, on the advice of Lord Darcy, when he did his review, which has led us to the 10-year plan, made it quite clear there were too many targets, for example. So we've tried to be more supportive and, if I can use the word, permissive with ICBs as the local experts. And there will be hiccups, but I do actually think fundamentally that is right. Because who else will know the area better than the local ICB? Nobody.
And of course, the ICBs are going through quite substantial reorganisation and actually, big challenges to their budgets as well. So how from the centre are we going to ensure, however the details are that are locally driven and locally designed and fit the local population, how are you going to ensure that with those budget constraints that are quite significant coming into ICBs, that actually they're still going to deliver on these objectives, particularly, as you say, for 51% of the population?
Who wants to talk through our thinking on it?
We've been clear with ICBs that we want them to continue with hubs or explain, and if not, explain what they're doing instead to meet those outcomes that we need, including experience. And Baroness Merron meets regularly with senior NHSE officials to monitor that progress and so we look at ICB plans and potentially challenge them. And we have heard from integrated care systems how positive women's health hubs have been for access and experience. And also we have cost-benefit analysis showing a £5 benefit for every pound spent, which is compelling. But Sue might want to say more, because this is...
Yeah, and I think from an NHSE perspective, which I guess is really where it sits, is that there's a lot of work afoot to support transformation. So, for example, in the way that new funding models are being designed to help to drive that strategic and transformational change. So that's happening not just in women's health, but across the board. And, you know, when you talked before about things like single point of access, that's being driven as a way to transform services, and the funding models that's available will meet. And then ICBs locally will determine their bits of their budget that might be directed towards transformation. And I know that kind of varies according to local area.
And perhaps just one general point, again, it may be stating the obvious, but funds are important, but we can, you know, I think, again, experience tells us we can put monies in, but what matters is not monies in, and I know you weren't saying this, but I just think it's very important to put it on the record. It's outcomes. And that's why reform is such a big part of what we're talking about. We're actually saying the system, and Lord Darcy said this, the system isn't working. So we can keep propping up the system, or we're doing something more difficult, and it is more challenging, but I honestly think it's the right thing to do, and I accept the point very much about ICBs. Similar point I would say about NHSE and DHSC. Lots of uncertainty because of the changes, but you have to go through discomfort to come out the other end. And I think that's what to use a well-worn phrase, we are grasping a few nettles that haven't been grasped, and that doesn't come painlessly. I do accept that, but I also don't think it's painless to stick around with models that aren't delivering.
Very much.
Thank you. Very briefly, if I could just check something, if you could just sort of distill down to us in one sentence, is there going to be guaranteed funding for the hubs? Is there going to be guaranteed funding there for the hubs? Because I couldn't actually discern from what you were saying if there'll be guaranteed funding.
There isn't currently, because what happened, it was the last government set up this initiative on women's health hubs, which was a good initiative, and they did provide funding for the first year, I believe, to get them going. That target's been achieved. It's the reason it's not in the planning guidance, because the target was achieved. So it was only ever there for a year. But women's health hubs, in my view, are, I can't speak for every area, but they are a very efficient, financially efficient and outcome-driven solution for an ICB who are seeking to provide, as they are required to do, the right healthcare for the women and girls.
So we'll have to move on to her, but it sounds very much like you're saying it's not guaranteed going forward. So if we could move on to just talking about managing women's pain, I wonder if you share our frustration about the slow progress in improving the management of women's chronic pain and procedural menstrual and gynecological pain.
In a simple answer, yes, I do.
Okay.
And that is why, and Tabitha mentioned this, it was I was very keen to include this as one of the round tables of bringing together women with lived experience, professionals, third sector organisations, NHS, etc., to talk about this, to feed in to the women's health strategy. Yes, I've heard many experiences that are quite staggering.
And will there be measurable actions as a result of these roundtables and things in the strategy?
Well, again, Sue might have something to say on this, because it's NHSE who we've tasked with advancing the work on pain management, which also includes bringing together people on trauma-informed care, patient safety, patient representatives, and we're looking at reviewing what's available already, literature and research-wise. But key in this, and I'm sure the committee's heard it many times, lived patient experience. I don't think there's much that's more powerful than that. And let me say to the committee, it is absolutely unacceptable that women have such poor experiences, particularly in pain management. It's been quite a lot in the House of Lords chamber particularly, and outside the chamber, to me directly on hysteroscopy. delivered, well, hysteroscopy, quite staggering, I think staggering and shocking.
What processes do you think you will be put in place now, or would you like to see put in place to assess the progress, and when would you think we'll see some tangible progress on this?
I think we need to review what the training needs are. We need to have a greater priority on recognition and management of pain. We need to, we're back to systems now, strengthening approaches to how it's dealt with. And there are gaps in care, so we need to identify them and then to plug them. But perhaps, Sue, because this is your area of work very much.
Yeah, very much so. And actually, we are doing a fair bit in NHS England around this, and it should form part of the strategy coming forward. But absolutely agree that progress is unacceptable, and people are still having terrible experiences. When we think about procedures, mainly what we're talking about is hysteroscopy, things like IUD insertions, and sometimes just vaginal examination. So there's a number of things, a number of sort of places that we're putting our energies. We have engaged quite a lot with some of the groups who represent women who've had poor experiences. So there's a group called Tiger, and there's the Campaign Against Painful Hysteroscopy. It's really important to hear their voices, which we have been doing. So there's something about supporting women to get the right information, which is one thing about, what they can expect, how to make informed choices. So that's the sort of first part of that. The College of Sexual and Reproductive Health are doing a campaign at the moment alongside this about IUD insertions, painful IUD insertions. So really with the same ideas about trying to raise awareness amongst women and then amongst healthcare professionals. Second is around training the people who are doing the procedures. And we are thinking about, first of all, broadly, how can we better support trauma-informed care, compassionate care, culturally competent care. So thinking about some really basic principles that should go into training for delivery of women's health care across the board, whoever's involved in that. So that's sort of core principles. And then thinking more about what is available within the system. So there are new pain relief options, anticipating which women might experience more pain and trying to have a shared decision-making approach to that. And then more long-term, really trying to listen to women's experiences and measure them effectively so that you're not asking someone straight after a procedure that, how did it go, but really trying to stand back and say, how can we usefully measure how well people kind of tolerate those procedures, because they're never going to be nice, are they? And then use that to say, well, we need to have a standard of care here. And then the last thing I'll say is there's some really interesting innovations coming online, which we're trying to support around actually avoiding hysteroscopy if you don't need it. So there's some new tests around things like testing for cancer of the uterus. So you could maybe in the future be able to do that with a swab, and then you might not need a hysteroscopy. So we have to be very careful about how we introduce these things, because they've got to be equivalent to a gold standard. So there's all these things that are in train, but they're not quick. And I think that's, something we have to be realistic about.
And to your point about by when, the other area that's worth highlighting is by 2029, and I will have to read out what they stand for, forgive me, PROMs and PREMs. So PROMs, these are metrics. For anyone who's not, there's no reason why you should be familiar. So PROMs are patient-reported outcome measures. Already, and the key thing here is that already in use in orthopaedics and mental health, but not in this area. They measure the impact of care from the patient's point of view, not the clinician's point of view on what has happened. And PREMs are patient-reported experience measures. And again, we're going to be collecting them in a much more systematic way. So that will be, by 2029, they'll be used universally. So they're not currently. That, I think, will make a big difference. And they'll be published in the public domain. Also absolutely key.
That all sounds very much like a lot of awareness raising and measures to relieve pain, but going along with that is accountability. So do you think we can add, or how can we add, some accountability to the system? Because one of the things we've heard throughout this inquiry is that women, their pain is kind of put aside and dismissed and just put up with it. So do you think we need to add some accountability to that, and how do we do that?
I think what I've just said will help, actually, because those metrics will be used, and because they're published, I think, it's not going to look good to have a bad score on those metrics. They're publicly available, so if you're choosing which you can, choose where you go for your care. I know for a lot of women that's just not practical, but there is, you can indicate your view on when you're choosing your provider, and it will be on the NHS app, for example. I think that will hold to account. I should also credit the membership of professional bodies for their work. Sue did make mention of that, but like the Royal College of Obstetricians and Gynecologists also, they've just outlined their guideline on outpatient hysteroscopy. All that supports all that we're saying, and will support women to have a better pain control experience. And of course, what you don't know, you can't ask for. That's the other point, or challenge.
Thank you very much. I'm just looking at the time where there's a lot to cover, and obviously we want to go into it. I wonder if we could try and keep just a little bit shorter.
Tell us.
Just to make sure we'll be
glad for the help.
Just to make sure we get through everything. Yeah. Alex.
Thank you. I just want to come back to the very first point that Kim asked around whether your strategy is going to include the concerns that we're raising in this inquiry. And you said it might depend on timing. And I just wanted to add that the clues might be in our questions today as to the kind of areas we are interested in. And I wanted to follow that up with a question, which is, have you taken on board our report from a year ago about medical misogyny more generally, and the concerns and recommendations that this committee has raised in that report?
You're quite right to pick me up on that. And indeed, in some ways, we don't need to wait for a report, because but I would say that a number of the areas that the committee is looking at, and I'm grateful for it, chime in with what you won't be surprised, they chime in well, but that helps me as far as I'm concerned, so thank you. On misogyny, I'm sure you heard the Secretary of State, unusual for a Secretary of State to be, I may be being unkind to previous Secretaries of State, but I'll take the risk. But Wes was absolutely clear that medical misogyny has no place, and so that is and so your report is extremely helpful in that regard, for sure. We do, when committees report, I'm personally very keen on the reports, because so much of the good work, both in the Commons and the Lords, it really assists us. And we'd be daft not to be honest, to not take account of what's said. And of course we do respond to reports as is required. I like to be as positive as possible. If we can't accept a recommendation, then we will explain why. But I tell you what it does do for me, it makes me question and challenge, and the same for officials.
Good, thank you. That's good to know. We heard a good deal of evidence, so I'm pleased to hear it. So I have quite a long list of questions, so I'm going to push on. Do you think there should be a link to the Wellbeing of Women's period symptom checker on the NHS website?
Yes. And
what are the barriers to making it happen?
Within 6 months, we are using the next 6 months for NHSE to look at how best to do it, to make sure it all works, etc., etc. Because it sounds, to those of us who are not very technical, and I'm sure that every member of this committee is extremely technical, but I am not. It sounds very straightforward, but I'm assured it is not. And actually, I believe that, because I want to make sure it works. But the answer is simply yes. It's a great thing, and we want it out there.
Okay, 6 months still seems a very long time from where I'm sitting, but okay.
We could expand, or we can write to you on it if you would like.
I think the committee would be very interested in understanding exactly what the barriers are to making that happen.
Absolutely.
Thank you. So do you think the NHS should be making more use of third-party media content produced by effective women's health communicators like Dr. Cisse and Dr. Arif, for example?
Yes, and we try to do that.
Okay, excellent. I mean,
am I doing better?
Yes, thank you. We've heard a lot throughout this inquiry about the difference between the acceptability of naming men's genital parts and so on, and the taboo of naming women's body parts, and therefore there is significant work going on to combat this. And they told us that NHS bureaucracy might be preventing some of their menstrual health content being published via NHS social media channels. Would you take action to streamline that bureaucracy?
I think that maybe that's not an NHS thing, the social media regulation. As I think that is DSIT, the Department for Science and Technology, with the Online Act, trying to do the regulate harmful content, yes. And then whether it's successfully distinguishing between harmful content and helpful content, yeah. And we are very keen to advocate for a better, for that distinction to be right. And
that was my next question, but this is specifically about it getting onto NHS social media channels.
I may be misunderstanding the question, but I guess we're all thinking about it from, for example, TikTok, for example, to access the information. It may not happen because of the way their platform works. And we do think that's an issue. But the question that you asked was about...
At the moment, the NHS is sharing that, because one of the ways that young women access health information, and not just young women, it has to be said, but, is through social media channels. It's TikTok, Instagram, etc., etc. So in order for them to do that, it obviously needs to be pushed out via the right channels, and then has to not be deprioritised or shadow banned by those social media algorithms. Okay. So these are two separate things that I'm looking at. So the first one is it going out on NHS channels?
Should I answer that one? So NHS does have social media channels, so we do use kind of YouTube and things like that. I think that there's obviously a bit of a tension between the need for safety. So I think that the NHS England really, in terms of information, prioritises kind of, can we share, is this the best information to share? So there's a lot of layers of scrutiny, and that's what makes it a little bit more difficult. And I do understand that the pace of change and important kind of influencers like Caesar and Nigat, have got really good, push out very, very effectively into the system. Trying to marry those things up is complicated because of the controls that are in place, I guess, to ensure for every information source that's coming in, to ensure the quality and safety of that, which is not just the high quality stuff, but it's a whole mixed bag.
Perhaps I can just say that I understand the issue completely and I'm sympathetic to it. It doesn't sit within my gift, but I am in the process of raising it with DSIT ministers. I can't speak for them at this stage. It may be something the committee would want us to come back on, but that is what I'm doing, because I absolutely recognise the point you're making.
Thank you. I'd be interested to know, are those conversations that you're having, will that feed into the women's health strategy as a part of it?
I think it's more likely, as I say, that if I can be a bit broader, the women's health strategy will indeed talk about how we get, we will be looking at how we get our information out and making it appropriate to different groups who receive, as you say, their information in different ways. Where there is a block, as I say, if there's a DSIT matter, that is what I will raise. That will be separate to the women's health strategy.
Okay, so I mean, my concern as a woman, as a parent of a teenage girl and boy for that matter, is that we are living currently in an age where teenagers can go onto social media sites and strip someone naked digitally, but cannot access accurate information about their own bodies. And that feels like a problem. It's a digital problem, but it is a health problem. And so what I'm sort of trying to dig at a little bit more here is to what extent would you be working with DSIT? Do you share their confidence that the Online Safety Act is enough to help prevent this? How much joint working is there going to be between the two departments, or is there currently?
I probably can't answer that directly. I haven't got a direct answer. But two things. One, as we said, we do use the various platforms, YouTube, Instagram, Facebook, for the very reasons that you've explained, to explain topics that we're talking about here, including menstrual health. We know that 18 to 34-year-olds are not very likely to go on the NHS website. Some of us might, but we're not in that, but not that group. We know that, and therefore we have to work with that. On the, but I am going to raise this point about, I'll use the term shadow banning, which you also raised, with, as I say, with DSIT. I just haven't got the information to be able to share with you, or I would have done about that.
So this is very...
But I will be explaining, and in fact it will help me, I can say this was raised with me at the committee as well. But it is a whole area for the government, actually, and not just exclusively, as we know, on women's health. But I'm saying I get it completely. Doesn't sit within my gift. And actually, the online safety bill will only cover certain areas. I'm not sure that it deals with shadow banning, because it's more about regulation than being, I'll use the word permissive I don't mean to be permissive, I mean to allow. Yes.
Yeah, I mean, this is something that is very definitely...
Yes. Well, and I'm grateful to you for making the point, actually. Thank you.
That's okay. So can I take it then that you haven't specifically had conversations with social media platforms about stopping this, but you would raise that with DSIT instead?
We wouldn't. That would be DSIT's responsibility. But we would raise it with DSIT, and that's what we're doing. Okay. Yeah.
Thank you, Nia.
Thank you very much indeed. If I can turn, first of all, Minister, delighted to see you, to Femtech, and just pick up on some of the things which the committee has looked at before I joined it, so I can take no credit. But first of all, if we start with the 2022 strategy, and asking you really whether you think it got the right balance between embracing potential benefits of, I suppose you just call them commercial products like Femtech apps, with things like period trackers and mitigating the risks that they could pose to women and girls. And linked to that then, what options have you considered for regulating, and how do you actually see the NHS's role in Femtech developing over the next few years?
I think it could play a greater role, and the renewal of the Women's Health Strategy will acknowledge that, because, as you rightly observed, the original Women's Health Strategy didn't really grasp it. It's perhaps one of the gaps that I was keen that the digitisation point I was keen to see. So, because digital health technologies are our way forward, and they will continue to develop. So I think probably what I should say to the committee is we're improving the process for digital health technologies to set the standards that your question is seeking. So we do want to embrace it more, and they are absolutely an ever greater part of the care and treatment that we are providing, and not just in terms of women's health, but that streamlined route to assure and to evaluate their use and practice, I think is really key. And their use does vary widely across the NHS. And again, we want to make it more widely available, taking into account not everyone can access digital health technologies. I think that point has raised me a lot in the House of Lords chamber, as you will imagine.
I'm sure.
Yes.
And I'm going to look at the reverse of that in a moment. Dr. Mann, I understand that back in November 2024, you actually told this committee that a call had been issued for femtech proposals, and I wondered what had actually come of that, and also if you've got any more to say about the femtech strategy being set out in the Women's Health Strategy. And if I can just pick you up on something else which you told this committee, you said that the NHS has a whole team looking at innovative things. And I just wondered what the gender balance and age balance and other characteristic balance was on that team. Are we looking at a lot of middle-aged men, and do they know where teenage girls access their social media? And does it determine which innovations they look at more quickly than others? In other words, are we going to fall in the same trap as everywhere else in the health service, where research into women's issues is lower down on the list?
Mm-hmm. No, very good question. And I actually, so there's a number of things there. So the team that I think you're talking about is the Innovation, Research and Life Sciences team. And they have a very, they're constantly evolving a strategy to look at how to bring new innovation and tech to actually reach people. I can't tell you the exact makeup of that team, but I take the point that you're making, and it's a small team. I would say that they are really aligned with us, and they are taking, women's health has become quite an important priority for them. They do a number of things. They kind of they demand signal. So say like, we're looking for innovations in particular areas. They support innovators to bring things, to develop and then to bring to market. And that fund that you were talking about, I think it was, I forget the acronym, but it funded a number of individual projects. It did actually do that, and I would need to check as to where those have got to. I don't have an immediate report on that, but definitely the funding went out to innovators. I would say as well that they work very closely with what we call the Health Innovation Network. So they sit in the region. So bringing that tech and saying what are the needs of this community, what innovations are happening locally. So it's a kind of quite a symbiotic relationship. I know for sure that there's a very large female contingent in that team of people working out in the regions, and often are the ones who are looking for what the need is and where the innovations are happening. And there's some interesting sort of tech that's coming through. There's a lot of tech around things like management of incontinence. There's tech around things like CBT for menopausal hot flushes. So that's another one that's sort of coming up the agenda. So there's some really interesting things that are happening. And of course, we stick much more to the what's called medical devices side of things rather than the more wellbeing apps, because those are the ones that really need the regulation and the development.
Thank you very much. And if I can return to a couple of more general things. Minister, you said that 85% of people on gynecological waiting lists are actually really to be treated in the community, not in hospitals. So does that beg the question about whether there shouldn't be a huge input into GP training, followed by a suggestion that anybody on a waiting list should actually go back to their GP?
It does raise a lot of questions. I think actually the main thing it raises for me is the need to focus on the waiting list to guide and support women to the right place. I think, Kevin, you also, or I think it was Kevin, also raised the 15%, 85%. Because I think maybe Leslie Regan may have said it earlier in the committee. So GP training is key, of course, but now GPs are incentivised to seek an opinion before, and that's a relatively new system, isn't it? To seek an opinion from the consultant before they actually send them to the consultant. And I think that is a whole different way of doing things. So encouraging, in fact, we don't just encourage it, we incentivise it. So that is happening. I think the difficulty we've got is people have been on waiting lists a very long time.
And then one last question, but last but definitely not least, is, with the new strategy coming out, what steps are you taking to ensure and involve disabled women in helping to design and improve the opportunities they have for access to the right information and treatment for their menstrual and gynecological care?
Well, in our consultations and our, number one, the consultation, which was massive, on the 10-year health plan, absolutely was focused on ensuring that all groups were represented. So that was the first thing. And of course, we're looking to that for, as I mentioned, the beginning of the committee. But also as we've drawn together people with lived experience, but also as we've drawn together third sector organisations, professionals, at the core of it has been ensuring we've got a wide representation. And you are absolutely right to talk about disability, because that very much affects people's experience. And I've spoken to one of our colleagues about that very matter, who experiences it very directly.
Thank you. I wonder if we could just very briefly, something I was wondering about, women with some conditions like polycystic ovary syndrome may have problems with the fertility. So should women in this sort of position have more support from the NHS and have their eggs frozen? It's not directly related to what we've been talking about today, but it's something we are looking into.
We don't have a policy in that area. Just to say, very recently I met with Michelle Welsh MP to discuss PCOS, and it is something very much in our sights, and I very much recognise we could do a lot more. We didn't discuss this point, Chair, that you raised, so I can't say, if the committee is going to recommend that, of course we will respond to a recommendation. I don't want to preempt that, but I can't say that is currently something to which we're committed. Is that fair?
I think that's fair, and also I think women with PCOS experience a range of different fertility problems, sometimes, not always. I think really important to say that. And one of the most common kind of problems that they have is that they have eggs but they don't release them. So sometimes the most effective ways of managing that, they definitely need to have sort of multidisciplinary care and good access to fertility services. And the ways of doing that and the best treatments for them, I think it needs to be sort of locally shaped with the services. And sometimes that is to stimulate egg release because the eggs are there.
Thank you very much. Thank you all for coming along and for your evidence today. I think we've covered everything. So, thank you very much. Order.